Okay, well, I'll get started while people continue to log in. First of all, good afternoon, everybody. Welcome to UAB Pathology Grand Rounds. And Dr. Payne pointed out, it's funny how things come around. I asked him a couple weeks ago to fill in for some cancellations and shifts we had. And then this afternoon, I'm doing the same for CCBC. So karma does pay back. But hopefully you'll join me in welcoming Dr. Payne, who's here at UAB. He started his training at Yale before completing his dual MD PhD degree at Indiana University. We were then fortunate enough to recruit him here to UAB as a postdoc in 2015, where he really excelled in finishing up his training, both from the research side as well as from the clinical side. And we were able to keep him here in 2018 as an assistant professor. During the subsequent 3 to 4 years, he's really excelled and is now also the assistant director of the MSTP training program here at UAB. He's received numerous awards, 2 recent ones where he was the inaugural recipient of the AHA, or American Heart Association, Harold Amos Medical Faculty Development Program Scholarship. And he also last year became a fellow of the American Heart Association. He has several interests in addition to his role in guiding the next generation of dual degree scientists. And he's also co-directed the Translational Research Program for Complex Cardiopulmonary Diseases at UAB, as well as investigating several novel inflammatory pathways at this cardiovascular pulmonary intersection. He has 3 active grants, one from the AHA, one from the NHLBI, and a local UAB one. And despite having only been faculty since 2018 and carrying both his research and clinical duties, already has 20 publications with a very recent JCI Insight paper last year. With that introduction, I do not want to take any more Dr. Payne's time, and I will turn the reins over to him, where he will tell us about Matrikines and smoke-induced atherosclerosis. Thank you, Dr. Payne, for accepting our invitation.
Adam, I appreciate it. And if y'all can see my screen, just give me a thumbs up there. All right, perfect. Well, again, I really do appreciate the opportunity to talk with y'all this afternoon. I have worked either directly or indirectly with a number of you and have long thought very highly of you all. So I really do appreciate the chance to share some of our work that really has been collaborative. And I think I'll point that out as we march through much of this. To start off, of course, I have no conflicts really to disclose. So as a way of overview of a presentation today, we'll just start off briefly talking about what I think all of us are probably aware is the pretty persistent clinical impact of smoking and its relation to cardiovascular health. And within that, Adam really alluded to a lot of work that we do kind of looking at the overlap or intersection of pulmonary disease and cardiovascular disease. And I'll really highlight why we really focus on smoking as a potential comorbid driver or relationship between these 2 organ systems. We'll then move into really what has been dogma for years, looking at some of the expected pathogenesis of smoke-related atherosclerosis, and really highlighting how the endothelium, or that inner lining of the vessel and vasculature, is thought to be a critical initiator in that disease process. Then expose you for a concept that has probably been presented in this forum before, but really highlighting the importance of the extracellular matrix as a driver of atherosclerosis, but really honing in on specific matrix-derived chemokines or matrikines. And while we think some of these agents, most notably proline, glycine, proline, and its associated peptides, may have some active agents, either in driving disease or as a biomarker for underlying disease. So with that, the learning objectives today are, number 1, really to just understand the cardiovascular complications associated with smoking, and as well as that relationship between cardiovascular and potentially cardiopulmonary lung disease. Number 2 is really understand how disruption of the extracellular matrix is thought to contribute to atherosclerosis. And 3, of course, is just to identify matrikines, specifically, again, PGP, as a potential biomarker for incident coronary atherosclerosis. So amongst a group as diverse as this, I'm sure we're aware that smoking has really been a challenge for the better part of 3, if not 4 decades. And despite what have been really robust efforts from a public health standpoint to really mitigate and decrease the desire to smoke or the prevalence of smoking, we've seen that it really remains a pretty prominent global public health epidemic. And as you can see here, there's approximately 34 million US adults that continue to smoke cigarettes. Now, if you really peel back the onion a little bit more on just that raw number, you'll see that there's really marked disparities across these US citizens that are smoking, such that those with a lower education, men more than women, unfortunately younger adults, and as many things when it comes to disparities living in the South or the Midwest, we see that those numbers are actually even more prominent. Now, looking at this, I found this slide interesting, which is really looking at the prevalence of smoking or association with vaping or some type of electronic cigarette amongst 12th graders. And you can see here that the percentage of really our youth had really steadily declined for, again, 2+ decades. But again, with that introduction of vaping and new kind of novel ways of smoking, we've seen a rapid increase in what could be both cardiotoxic or pulmonary toxic agents that they're inhaling. Such that right now, we know that about 16 million US adults continue to live with a smoking-related disease. And this is definitely an underestimate because, again, it's very difficult to assess the long-term implications of secondhand smoke exposure. And while I focus primarily on US citizens, I think it bears worth stating that many of these issues are going to be on a far more global stage. So you can see here that citizens in China or India really are smoking at a much higher rate than we're seeing here in the United States, and such that the disease complications from this probably will bear out far more stronger in those countries. Now, what really is understood well is that there tends to be a dose-dependent response or relationship in the development of either ischemic or cardiovascular disease and COPD or chronic obstructive pulmonary disease. On your left here, what you'll see is that there tends to be a pretty linear stepwise progression from those patients who have a reported number of cigarettes they're smoking per day, and then the relative risk of their development of ischemic heart disease. You'll see in a kind of similar fashion amongst those patients who were smokers who have developed COPD that as we kind of march from the left to the right on the x-axis here, you'll see that for those compared to never smokers, for those who are active smokers, there's an increase in the proportion who have COPD as well as in the increase in the likely more severe disease phenotype. As you might expect then, a lot of research has looked at this overlap, again, of cardiovascular complications amongst those patients who have underlying COPD. And what you observe is that there are increased hazard ratios for those for the development of ischemic heart disease, of heart failure, of atrial arrhythmias, as well as some of the other very common risk factors such as diabetes or other vascular changes in the lungs, such as pulmonary hypertension. And again, I think it's important to note that approximately 1/3 of patients with underlying pulmonary disease, such as COPD, will actually die from a cardiovascular event, as well as that the cardiovascular mortality dramatically increases with the decline in lung function or FEV1. So as you might expect, much research as well as ours has really looked in trying to uncouple if there are mechanisms that may link concomitant or comorbid COPD and pulmonary disease with well-established cardiovascular events. And that's really what drove us to looking at smoking in particular as a potential driving mechanism to study. Now, as you can imagine, smoking and tackling smoking from a basic or translational standpoint can be rather difficult. This is in part due to the fact that tobacco can produce numerous, if not up to thousands of different chemicals with burning and inhalation. And I highlight just a few here, including carbon monoxide with the insert of electronic cigarettes and other vaping systems. You can have increases in lead within the batteries. And then other chemicals that are far more familiar to us in the lab, such as formaldehyde, acetone, or acetic acid. We can see there are a number of agents that could have both overlapping mechanisms as well as unique mechanisms driving toxicity. One thing that has been well accepted somewhat as dogma, referred to as the response to injury hypothesis, first proposed by Dr. Ross back in the 1970s, really has been this idea that with this chronic insult or injury, that if it's left unabated or continued smoking, and this could also be inserted for hypertension or diabetes, that this ultimately impinges all towards the endothelial cells. And so these cells can become dysfunctional. And that if this axis or activity of injury leading to endothelial cell dysfunction is really left unchecked, it will lead to leukocyte recruitment, invasion into the wall, activation of smooth muscle cells and proliferation, and ultimately that hallmark of atherosclerotic disease, such as neoendomal formation. But Dr. Roth's hypothesis has really driven the field for a number of years, looking at the endothelium as that critical initiator in this atherosclerotic process, and smoking would fall right within that. Now, updates from that hypothesis have really put inflammation and many of the cytokines and chemokines from inflammation at the forefront of driving this, and such that the injury is thought to still be important, but these vascular signaling molecules are thought to provide that local blueprint for disease. Endothelial dysfunction is still important, but it also has broadened out in its definition, such that there are changes in increasing endothelial permeability, again, allowing for trafficking inflammatory cells to invade into the wall, as well as there's been identification of a number of proliferative and pro-inflammatory cytokines that are known to be important for driving disease. And again, classically, this known imbalance between an increased endothelin-1 production as a pro-proliferative or pro-inflammatory agent, and a decrease in what is thought to be a vasodilatory and anti-inflammatory agent in nitric oxide. Such that the current path or understanding of our pathogenesis of atherosclerosis disease or smoke-related atherosclerotic disease, again, is that with this injury, there is a invasion and release of key cytokines, proteases that can cleave a number of active agents, leading to what is thought to be a chronic, somewhat feed-forward mechanism of inflammation. Now, despite this understanding, again, from animal models and preclinical work, the importance of inflammation has really been well established, but targeting that clinically has proven far more challenging than was probably initially set out to be. So the original information that we really can pull from clinically was discussed in the Jupiter trial back in 2009. And so from this trial, we had approximately 15,000 patients. And in this case, they were randomized either to receive a placebo or to what we call nowadays high intensity statin therapy, in this case, using rosuvastatin or Crestor. And the somewhat interesting idea behind this trial was, not only were they looking at the response in LDL as a cholesterol agent, but also looking at markers of inflammation, in this case, high sensitivity CRP, and looking for a reduction or change amongst these groups. And the somewhat seminal findings from this trial were, one, that the best cardiovascular implications were from those who reduced LDL, as well as had a decrease in their circulating high sensitivity CRP. Now, this trial has been fraught with questions, including some difficulty in replicating it, but it really did drive the field as far as looking not only at the CRP pathway, but also has driven a lot of the targeting for anti-inflammatory agents and trying to mitigate cardiovascular events. I show you here, which is the pathway or the production that leads to production of CRP. And this is where the NLRP3 inflammasome has really taken hold. And as you can see here, whether it be a response to hypercholesterolemia, perhaps netosis, or the production of neutrophil extracellular traps, or smoking itself, it's known that this can really set in motion this activation of the inflammasome, leading to the production of interleukin-1 beta, interleukin-6, and then finally our in-target of C-reactive protein. Such that really in 2017, what was really a seminal trial here, which was the CANTOS trial, trying to target in one of those intermediaries in the production of CRP. And what was observed here now in 10,000 patients who were really enriched as far as their risk factor profile, as all of them had had a prior MI, as well as all of them had evidence of kind of underlying inflammation with a CRP of greater than 2. This patient group was either randomized into a placebo or to a monoclonal antibody with interleukin-1 beta as an antagonist. Here, what they observed was that there was about a 15% relative risk reduction for those who had been randomized to receive canakinumab. In follow-up trials, instead of targeting interleukin-1 beta, a second CERT trial or cardiovascular inflammation trial looked at about 4,800 patients, again, all high risk, but randomized in this case to methotrexate, a known antagonist for interleukin-6. Interestingly, they did not see many changes in outcomes, but also failed to see any reductions in any of the circulating cytokines, including interleukins-1 beta, interleukin-6, and CRP. And then finally, I'll leave you again with probably one of the more recent trials, the COLCOT trial, which was using colchicine to partially antagonize interleukin-1 beta versus placebo. And again, they saw that there was a relative risk reduction of 22%. Again, amongst these patients, about 5,000 or so who were enrolled in this trial about 30 days after acute myocardial infarction. So you may look around and say, well, it sounds like there's been promising effort, but really kind of buyer beware. Some of the issues that have come up with this really hinge around the adverse effects that these anti-inflammatory agents have had. And that includes issues with neutropenia, leukopenia, as well as fatal infection, and most prominently in elderly and diabetic patients, of course, the very patients that we're most likely to see, as well as increasing risk for developing microbacterial infections. And with colchicine in particular, it's known that there's a risk of developing pneumonia, which was also seen in the COLCOT trial. So going through all of that, the question is, where does that really leave us? And despite, again, what has been now growing clinical evidence and really robust animal modeling, our preclinical work, we're still limited with kind of limited efficacy and concern of side effects for the agents that are available. And many of these agents are not readily used clinically in the prevention of cardiovascular disease. So for me and for many of us that are working with us, this really points to the need to continue to develop alternative mechanisms that may dampen inflammation in the fight against cardiovascular events. So that's where our interest in extracellular matrix really took hold. And I think it's important to understand that, as I'm sure many of us here do know, that the matrix is both critical for maintaining organ structure as well as function. And by matrix, I'm referring commonly to collagens and elastins that have any number of roles, and including binding proteins, as well as holding on to cytokines, as well as other versions of the matrix. Of course, extracellular matrix is abundantly expressed in a number of tissues, and it's been implicated in both states of health as well as states of chronic and acute disease. Specifically for us, if we look at the vasculature and zoom in on the vasculature, you can see that types 1 and 3 collagen are robustly and abundantly expressed within the intimas, media, and adventitia of these tissue. So separate from just looking at structure, of course, the extracellular matrix provides a number of signaling cascades, including promotion of cell survival, can add towards cell proliferation, adhesion, as well as cellular migration. So I think the key takeaway here is to really understand that the matrix is not a static structure, and that it has a very dynamic activity that is really undergoing consistent or frequent remodeling from activity of matrix metalloproteases that are actively cleaving the matrix. And so in that process, we can actually see that small fragments from the matrix will be produced, and that some of these fragments can be bioactive and previously have been shown to really drive both cellular activation as well as chemotaxis. So if we refer to them in bulk and refer to them as matrix-derived chemokines or matrikines, it's important to note that these matrikines are bioactive fragments, as well as MMPs have been implicated in states of chronic tissue injury and chronic inflammation. Now, MMP activity in atherosclerosis and cardiovascular disease is nothing new. I think it's important to point out that atherosclerosis in its initiation is thought to be important for plaque formation as well as in vascular inflammation, as well as it's been well reported for MMP activity, specifically MMP9 activity, is important perhaps for tipping what would be stable plaque into a unstable plaque and having plaque rupture. But what has not been examined until we decided to try and take a look at it was what effect, if any, do these extracellular matrix fragments or matrikines have on vasculature function, as well as does it have the potential to contribute to vascular disease. So with that, our matrikine of choice that we have focused on primarily for these studies have been proline glycine proline and its associated peptides. So again, PGP can exist in both an acetylated and unacetylated form. And it's important to note that it's a collagen-derived tripeptide matrikine that really has been shown to mimic the binding of a known pro-inflammatory cytokine, interleukin 8. And it can do this through a unique mechanism that we'll walk through, where it's actually able to bind the receptor for interleukin 8, CXCR2, and potentially, and had previously been linked as a biomarker and promoter of COPD. Now, PGP is actually generated through the sequential degradation, primarily of type 1 collagen, using MMPs 8 and 9, as well as a final enzymatic step where proline-endopeptidase is able to cleave and liberate PGP. And for at least locally, we've been only able to measure PGP through tandem liquid chromatography and mass spectroscopy. The general 10,000 square foot idea here is that in response to injury with an initial insult and invasion of inflammatory cells, what happens is that with that initial invasion, we have both active cytokines or canonical cytokines, as well as surrounding tissue damage that, if liberated, can set in motion what propagates itself as a feed-forward mechanism of driving continued circulation and invasion, primarily of neutrophils, at least from our understanding to date. As I explained in 2 slides before, one of the things we see is that with increased MMP activity, we can actually liberate what are smaller segments of the matrix, about 100 amino acids in length. And that with the onset or activation of proline-endopeptidase, we see that it actually cleaves between these proline bonds, liberating PGP, which then again can exist in its unacetylated or acetylated forms. Now, interestingly, when we looked at that receptor for interleukin 8 or PGP, the ELR positive family of chemokines, we actually looked at the structure of this. And if you look at the binding motifs of the chemokines that can bind those ELR positive chemokine receptors, if you zoom in really at the binding motifs, you do see that there's pretty conserved structure, amino acid structure of this proline glycine proline kind of repeated in the known structures, such that if you really look at a diagram here of PGP on top, or just the binding motif of interleukin 8 in this case, you can see that there's a lot of structural similarity, as well as, again, that this is mapping out towards where that chemokine would actually interact and bind towards its CXCR2 receptor. And again, I highlighted that prior to me either joining faculty or even coming in as a postdoc, a lot of the work extensively had looked at PGP as a potential biomarker in pulmonary diseases, including cystic fibrosis and COPD. But one of the questions we initially wanted to ask was, what effect can PGP or these other matrikines have on other cell types that are expressing CXCR2, and most notably endothelial cells? And what effect, if any, does it have with regards to vascular disease as it relates to smoking? So really, with that introduction, what I'll do is just start to march you through some of the evidence we've had, both from a molecular and cellular standpoint, looking at endothelial signaling in response to PGP, looking at some ex vivo or in vivo evidence showing that PGP has a chance to alter endothelial cell permeability, as well as alter endothelial dysfunction, as well as finally looking at some translational evidence that we've recently discovered suggesting that PGP may serve as a biomarker for patients with coronary artery disease, as well as the potential future steps that we'll be looking at to try and target this as a mediator against atherosclerotic disease. So first, when trying to understand kind of endothelial permeability, it's important to understand what are the key mediators of this. And I'll point your attention to the vascular endothelial or VE cadherin, which is known to be important for regulating the gap junctions between endothelial cells. And it's known that with an injury or danger signal, that there's an increase in phosphorylation VE cadherin that ultimately leads towards edema and the ability of inflammatory cells to transmigrate across the endothelial barrier. Now, work that I was involved with, but really led by Rakesh Patel and Amit Gar, really was the first to identify that CXCR2 binding on endothelial cells may lead towards activation of this VE cadherin and phosphorylation. And as you can see here, despite a number of different endothelial cell types, so coronary, aortic, umbilical vein, as well as pulmonary microvascular, you see a time-dependent increase in that phospho-ERK, suggesting that there's a chance for phosphorylation of that in-target and VE cadherin, as I showed on the last slide. Now, interestingly, if you actually expose many of these same cells to acetylated PGP, you again see a time-dependent increase in the phosphorylation of VE cadherin, again setting the stage that there may be changes in endothelial cell permeability. Furthermore, if you look at from a staining to see if it's specifically through that CXCR2 receptor, you can see on your right here that compared to controls, again, we observed an increase in phosphorylation of VE cadherin with the PGP, but importantly, this was ablated by the co-exposure to a CXCR2 antagonist, this SB225002 compound. So for those investigators as well as myself, we took this as information suggesting that PGP has the capacity to activate endothelial cells, again, through this CXCR2 receptor. Now, to take this a little step forward, they actually did a permeability assay, and this is an in vivo work, again, using an Miles assay for Evans blue injection. As you can see here in both our negative and positive controls, the injection of VEGF as a positive control leads to significant extravasation and increased staining of that blue dye. So using this model, we actually looked at PBS as a vehicle in comparison to PGP, as well as an inert tripeptide proline glycine glycine. And again, what was observed is that in comparison to PBS, again, as our negative control, we saw that PGP caused increases in extravasation, again, suggesting that there's vascular permeability. Furthermore, it was similar to the levels of VEGF. And again, our inert tripeptide had no significant effect. And importantly, all of this correlated with increases in phosphorylation, again, of that VE cadherin. So while those were some of the initial findings, kind of when I first was joining UAB, one of the big questions was what effect, if at all, does PGP have on endothelial cell physiology separate from permeability? And to give you kind of lead off with the spoiler here, the findings we had implicated that there may be an increase in endothelin-1 production amongst these endothelial cells. So here I'll point you to the figure on the right, which shows that for our control cells, those again being exposed to that inert tripeptide proline glycine glycine, or just being exposed with our CXCR2 antagonist, we had no significant differences in endothelin-1. But importantly, in response to interleukin-8 or PGP, we had a marked increase in endothelin-1 production that again was dependent on that activity of the CXCR2 receptor. Again, highlighting potentially that endothelin-1 production is driven through activation of CXCR2, at least in vitro. As kind of proof of concept, we actually looked at some of these cells under isometric tension studies, and albeit unpublished, what we observed here is that if we actually took aortic rings and just exposed them for 24 hours in culture, either with a vehicle or PGP, what we observed is that there was a marked decrease in the response of the endothelial-dependent vasodilation, in this case to acetylcholine, with various responses in endothelial-independent response to sodium nitroprusside, as shown on the right, and a very modest change in smooth muscle response in these ex vivo studies culturing with PGP. If we actually dose PGP into mice, in this case, healthy wild type mice, what we observed is that compared again to our controls, both interleukin-8 and PGP showed increases in aortic endothelin-1 production, as well as there was a modest but significant increase in the transcription for the endothelin-1 gene, EDN1. Importantly, again, this appeared to be dependent on the CXCR2 receptor, which if we co-administered the SB compound, we were able to rescue this observation and decreasing back to baseline levels of aortic endothelin-1. One of the questions that I think is often developed is the effect of PGP or peptides on the endothelium just a generalized inflammatory response. And I think this evidence here really points to the fact that it's not. It seems to be a specific effect. And this goes to show you here that PGP really did not drive some of the other key or known inflammatory cytokines, including MCP, interleukin-6, or interleukin-1 alpha. Such that from an in vitro or more cellular base, our current working hypothesis is that PGP can, again, activate CXCR2 on these cells, potentially leading to phosphorylation of that V cadherin, leading towards leakier or loosening of the gap junctions, as well as a potential production of endothelin-1, again, as a pro-inflammatory and pro-constrictive agent. But I think as the physician scientist would ask, the real question came down to what clinical relevance does this have, and do these changes in endothelial physiology and permeability really have a meaningful effect in the day-to-day life of the patients that I treat? So with that, we really pivoted to trying to look at translational work as well as clinical evidence that really may link PGP, the production of PGP, with known kind of established atherosclerotic diseases, as shown here, both peripheral arterial disease as well as coronary artery disease. And such that we really wanted to probe, is PGP a potential useful biomarker, as well as is it something we could target that may mitigate some of the known pathways with atherosclerosis? One of the first questions we wanted to answer was just, could PGP be produced locally, or is it something that was more circulating? And I think we used this model, which was a carotid ligation model, really as a proof of concept to show that PGP could actually be produced locally without systemic inflammatory responses that are ongoing. And as you can see here, again, compared to their sham controls, for those mice that again had a complete ligation of the carotid artery, compared to their ipsilateral untreated artery, we saw that for ligation, we saw a nice time-dependent increase and sustained increase in local PGP production from the carotid tissue, again, measuring out to at least 2 weeks. Importantly, in addition just to seeing PGP being increased, we also saw that important enzymatic machinery of protoendopeptidase also appeared to increase in response to ligation, really at an early onset of at least day 3. So to tie this in with smoking, we actually have used some whole animal models of mouse smoking. And what I'll show you here on top is really to show that while PGP can be produced locally, we can also induce expression of that PGP receptor in CXCR2. And so what you're seeing here are just immunohistochemical stains looking at mouse aortas from animals that are either treated with air treatment, hence not smoked for up to 6 months, as well as compared to those who have been smoked. And you can see that really within the vessel, there's pretty marked increases in staining for CXCR2. We took these initial observations and really looked to see specifically on endothelial cells. And as you can see here, that there have been marked fold changes if we expose endothelial cells to cigarette smoked extract. You can see a real dose-dependent response in the transcription of CXCR2, as well as the protein production of endothelial CXCR2, and both shown here by ELISA as well as flow cytometry. Now, one of the questions I think we often ask is, well, cigarette smoke really never directly interacts with endothelial cells and really should have to have some cell-to-cell connection. So we tried to see if we could recapitulate this in a co-culture model where we had alveolar epithelial cells cultured on top and exposed to cigarette smoke, as well as having pulmonary endothelial cells that again were co-cultured between a semi-permeable membrane. And what again we saw is that there was a marked increase in CXCR2 expression on those endothelial cells despite an indirect exposure to cigarette smoke. One of the things we're working on currently is trying to really pin down the potential mechanism or cellular mechanism of how smoke may be linking to CXCR2 expression. And one of the things we've looked at is looking at the inducible kind of transcription factor of aryl hydrocarbon, or AHR, on the screen. And so far what we've seen is that while we all have increases in CXCR2 for human coronary endothelial cells, we had a modest but significant change in the aryl hydrocarbon production, as well as in heat shock protein 90. And I'll tell you that these are active investigations that we're looking at, including inhibiting aryl hydrocarbon to see if we can reduce some of the effects of inducing CXCR2 on the endothelial cells. Now, despite the in vitro setting, we've also moved on to a transgenic approach to trying to answer this question. And here I show what has been a novel animal transgenic model of inducible endothelial CXCR2 knockout. And I'll really just point your attention to the stains here on the right, which show that compared to our vehicle-treated mice, we still have robust expression of CXCR2 in green, as well as on the endothelium, which is marked here by red. But with tamoxifen, we're able to actually effectively delete this effect in the expression of this receptor on this specific cell type. So utilizing this model in these mice, we actually again smoked these animals for approximately 3 months and saw again that deficiency of the CXCR2 on the endothelium actually tended to protect those cells from developing endothelial cell dysfunction, again in response to endothelial dependent vasodilation with acetylcholine. And in this case, it was unique in the such that the smooth muscle cells appeared to have no change despite our genetic manipulations. And it's on the bottom right here, you can see an example of how these mice have been smoked in a whole body fashion. So one of the avenues or aims we really look to move forward with, and again, I highlight support and help from Rakesh, has been utilizing the inducible hyperlipidemic model with the PCSK9 adenoviral vector for these animals, these transgenic mice. And so I just point again to highlight this model that really has consistent and preserved increases in circulating cholesterol, really with what amounts to a one-time injection. And so our plans are really to inject these mice and then expose them again to air smoking with a hope and to assess for evidence of atherosclerosis and vascular disease. And I just highlight here that when we measured PGP from these mice, again, not smoked, there were really no significant changes in PGP production or acetylated PGP. Again, owing to the fact, and I think we're banking on the fact that really smoking is a critical driver for setting off the production for some of these matrikines. So with that, with the remaining 10 to 15 minutes or so, what I'd like to do is just pivot to some of the clinical evidence we have that may link PGP as an important marker of underlying vascular disease. And so one of the first highlights we had of this was actually some of our work with the Spiromics trial. So this is a COPD cohort trial where we were able to actually measure plasma PGP and acetylated PGP as a biomarker amongst these patients. And what we were able to do is segregate these patients against those who had known cardiovascular disease, those who had known cardiovascular disease versus those who had no known cardiovascular disease. And I think it's important to state here that these were all self-reported evidence of cardiovascular disease. So we did not have access to patient charts or review of any information. It's just taken as truth when the patient says so. What we did observe is that amongst the patients with COPD that had elevated PGP, they were more likely to also have this self-reported incidence of cardiovascular disease. And if we segregated or split up these patient cohorts, we saw a somewhat stepwise increase from those who were never smokers and no reported cardiovascular disease to, again, those with active smokers with reported cardiovascular events. This really suggested us maybe it was worthwhile to look at our own local population. Again, owing to the limitation here that there was no adjudication of what was cardiovascular events or what was should or should not have been a established cardiovascular diagnosis. So with that very preliminary data and rough preliminary data, we really set out to use one of the local COPD patient cohorts that we have the fortune of having through our UAB Lung Health Center. And so the Prevent COPD study was an observational and is an ongoing observational cohort study of both current and former smokers, some of with varying severities of COPD. And enrolling from here, we were able to do a cross-sectional analysis all here at UAB. But importantly here, we had access to all their patient records. And so we are able to kind of provide adjudicated cardiovascular diagnoses after review from 2 physicians. And for here, henceforth, when I mention coronary artery disease, I'm defining coronary artery disease as a composite of both a prior myocardial infarction, prior coronary revascularization, so PCI or CABG, as well as a physician diagnosis of coronary artery disease in their chart. Amongst this cohort, you can see it was the demographics fit for what you might have expected. So age ranging from anywhere from the 6th to 7th decade of life. About half the participants were men, half participants were white. And they had a number of risk factors, as you might expect. So half of them with hypertension, about 1/5 of them with some type of coronary artery disease, and then lower amounts of those who had prior PCIs or prior CABG. And I highlight this just to say that the number of patients who had truly obstructive coronary artery disease is relatively low for this cohort. You can also see that the incidence of heart failure, whether it be preserved or reduced ejection fraction, was relatively low within this cohort. Furthermore, the majority of the participants, about almost 60%, were current smokers. And you can see furthermore, the various levels of lung function that were associated within these patients. What we observed, again, using tandem liquid chromatography and mass spectroscopy, was again that for those patients either with adjudicated diagnosis of coronary artery disease or a prior history of PCI, that there was a significant increase in circulating PGP. And again, one of the things we saw and often asked is about this very high value that we saw amongst the patient that was labeled with coronary artery disease. And as it stands for this preliminary results, we've left it in part because this actually was probably the sickest patient we had within our cohorts. They'd had multiple PCIs as well as multiple CABGs, but I'll address this again as far as limitations from our understanding in just a few moments here. Again, if we look as far as the stratifying these results, we saw that there was about a 1.26, or excuse me, a significant relationship from those, again, who had coronary artery disease. And furthermore, that was persistent amongst those who had had a prior PCI or prior CABG. Again, we did not see much of a signal for peripheral vascular disease or heart failure, but again, just understand that there were very few patients who fit these diagnoses. I think importantly, if we do logistic regression models, adjusting for COPD severity as well as smoking status, we saw that coronary artery disease remained significant, again, owing to the limitations that I've mentioned before. One of the questions I think we also wanted to address was that, is this just an issue with the CXCR2 receptor, or is this unique to PGP? And so what we tried to do was to measure a number of known cytokines that may have also been binding to that CXCR2 receptor. And as you can see here, measures from whether it be Gro alpha or again, interleukin 8 were both measurable, but really with no significant difference, unlike what we saw with PGP. Finally, one of the other steps that we wanted to look at was within a subset of these patients, we had CT scans, both of the lung and heart, from about 36 of them. And what we were able to do is measuring their PGP again, compare it to the level of calcification that we saw on the coronary arteries from these patients. And what we observed is that PGP again was correlated with right coronary artery calcification. And I'll just show you an example on the slide here below. So where does that leave us today? And so we're working right now with this idea that the PGP and its relation with CXCR2 is active and can promote many mediators of endothelial cell dysfunction, primarily endothelial permeability and potentially increases in endothelin 1. We have strong animal evidence that smoking can promote endothelial dysfunction both in vivo as well, separate from those in vitro models, as well as there's now growing implications that it's potentially that targeting that PGP cascade may potentially mediate atherosclerosis as well as potentially serve as a biomarker for underlying coronary artery disease amongst cohorts of smokers. Such that we're moving forward as if this is really just the tip of the iceberg of initial evidence that Matrikines may be important for the development of vascular disease. And Our future work is really going to look at some additional mechanisms in the production and breakdown. I'll highlight again protoendopeptidase, which is an active area of investigation for us, as well as looking at novel clinical biomarkers, whether it be PGP, acetylated PGP, or some of its associated matrikines that can also be produced. And all of this with the hope of trying to mitigate some of the ongoing epidemiologic crises of cardiovascular disease in association with smoking. So with that, I'd like to just take a couple minutes to really acknowledge support for this work. As Adam mentioned in the introduction, this work was initially supported by the Comprehensive Cardiovascular Center through their integrated mechanisms of cardiovascular disease, and then more recently supported by the Lung Health Center through their pilot research award. It's been supported by the National Institutes of Health, the VA, as well as personally through my career, K equivalent career development award of the American Heart Association through the Robert Wood Johnson Foundation. I think more importantly, I'd like to thank the people who really have allowed this to be possible. So my own lab, as well as collaborations with Mike Wells' lab, of course, my postdoctoral mentors, Amit Gagar and Ed Blaylock. And again, a special acknowledgement to Dr. Patel for his help in really thinking through a lot of these things, as well as some of the models he's really made available to us. So finally, of course, none of this is possible without the support and emphasis from the targeted metabolomics and probiomics of the mass spec core. And so we're greatly appreciative of them. With that, I'd be happy to give you your screen back and take any questions.
Great. Thank you so much for that very excellent talk. And I have several questions, so I'll ask one quick one while other people either type their questions in the chat or unmute to ask them for you. At the beginning, you mentioned a lot about some of these alternative smoking products that have come up, and you mentioned the potential contamination from the batteries and things like that. How much granularity have you been able to determine from the inflammation standpoint that these alternative smoking products and or with the legalization of other smoking products more recently have really impacted the development of inflammation?
Yeah, so to answer your question directly, not with much granularity. So one of the things we've looked at specific to our pathway of choice had been some of these acetyl groups and acetones, and acrolein in particular is an agent in smoke and can be produced with smoke that we think may be involved with promoting acetylation of PGP to acetylated PGP. So that's been one area that we've tried to probe through, but I think it's a good epidemiologic as well as scientific question as far as to if we're transitioning as a population towards some of the electronic cigarettes, are we going to see similar effects, or is it going to be a different type of pathology and phenotype? I will say off the top of my head, I believe there's been reports that kind of electronic cigarette smoking it may not be equivalent, but a cardiovascular risk with their use. So they're not benign or not protected by using just that. But I think it's an interesting question that we hope to kind of get to. One aside, I will say there are smoking channels and models that are trying to really target e-cigarettes in particular, so moving away from kind of lit tobacco products, but those models are available.
And what about even the more blunt question, pun intended, about like things in Colorado and other smoking products? Yeah.
I'm not sure, to be honest with you. I'm not sure. I can tell you clinically, we don't see as much as a strong association between those who are frequent, say, marijuana users or smokers or tobacco product. That may be because marijuana has been illegal for years and we just don't, people don't admit it to me, or we have kind of held down the denominator of people we're screening for it. But it will be interesting as it probably have a wave of legality kind of going across. But clinically, we haven't seen it, which is why a lot of it has focused on tobacco use. But again, cigarettes have been far more readily available than what used to be an illicit drug, depending on what state you're in.
Okay.
Greg, I have a question. I guess, Adam, you were asking that question for a friend, right? The last one. Two questions. in individuals after they've stopped smoking for a while, do PGP levels come back down? That's my sort of first question. So does it track with active exposure to the smoke?
It's interesting. They don't. So like if you look at the best answer I can give you is actually looking at the alveolar lavage from patients who have really have smoked and developed disease. So if you have gone on to develop, say, COPD and particularly potentially cardiovascular disease, it seems like there's a persistent smoldering amount of PGP. Now, if you just smoked incidentally, didn't smoke enough to kind of lead to a kind of pathology, I'm unaware or unsure of where the PGP values would go from there. What has been shown, again, with Ahmed and Ed, is that it's typically smokers had some elevation, but really it tipped off when they started to have signs of, again, parenchymal damage that was ongoing.
And so the follow-up is, what about the concept of prenatal exposure, smoke and other things that increases susceptibility long-term for that newborn to cardiovascular disease, Barker hypotheses and things of that nature. So has anybody looked at this pathway in that setting? No, not that I'm aware of that they have looked at it. It'd be interesting from the onset of, say, mothers who smoke or a mom who's exposed to secondhand smoke, if there's any differential programming that kind of gets set in motion from that standpoint. Now, it'd be an interesting question because it's from what we have seen, there's a potential that indirect exposure can set some of these pathways off. And so it may set the stage for, the children of someone who is a smoker exposed to smoke may be at higher risk. And I know clinically that observation has been made, but as far as I'm not aware of PGP or any other smoke-related pathway that has been linked in that way.
If there are no other questions, I'll ask one more. You kind of alluded to this at the beginning as far as some of the other comorbidities and the diversity in response, and dealing with two variables, smoking and atherosclerosis alone is pretty intense. But how much have you looked at complications that would increase inflammation to begin with, such as obesity, diabetes, and how much does that cloudy the waters for you?
Yeah, it muddies them quite a bit. So we have steered clear of asking that question. I think it's something clinically that's in our head. And it'd be something that'd be relatively easy to manage. I think the obesity and then metabolic syndrome becomes its own risk factors. But I think, when we looked at that prevent cohort and we're able, at least initially, to see that even if we adjusted for smoking status, that association of PGP and atherosclerotic disease was maintained, really gives us some emphasis to move forward with other more common risk factors that you're discussing. So obesity, metabolic syndrome, frank diabetes. And so we've got grants actually proposed to look at that somewhat independent of smoking, but just identifying those patients who have developed atherosclerotic disease and see if it's something that's active and unlinked from smoke. I will tell you from the animal perspective, again, hyperlipidemia, at least by itself, at least in our animals, doesn't seem to really drive that cascade. But again, it may have been a little bit on the early side, and it definitely was before those mice would develop frank atherosclerotic lesions. So I think we've got a little bit of work, or a lot of work, as far as looking at the timing and development of some of those known risk factors.
Good job, security, for sure. Well, and I assume moving forward too, we'll probably hear about some intersection with long COVID and other more sustained inflammatory states as well. So
Absolutely.
Plenty of future work for you. Okay. Well, if there are no other questions, please join me in thanking Dr. Payne again, and enjoy the rest of your afternoons.
Thank you all for
again.
having me.